Hello and welcome. My name is Peter King. In this presentation, I want to talk about evaluating the effects of depression and the impacts on life expectancy in cancer patients. The objective of this presentation is to analyse how the diagnosis of depression in cancer-free and cancer patients is carried out. We will also be exploring the impact depression has on life expectancy of cancer patients and the treatment methods used. The structure of this presentation is divided into 7 main parts. To start with, we'll be looking at the Hospital Anxiety and Depression Scale, a method used to diagnose depression. Secondly, we will explore the validity of HADS as an assessment method and question if this is a reliable method for diagnosing depression in cancer patients. Can this method provide a misdiagnosis of depression due to other factors? Thirdly, we will briefly look at the various symptoms of depression, some of which are quite unexpected, due to them not being generally associated with depression as a whole. Some of the symptoms of depression in cancer patients differ quite dramatically. My fourth point looks at how depression affects the life expectancy of cancer patients. This point also takes us to the next slide, which explores the impacts of life and reduction of quality in life, which has an effect on overall mortality in cancer patients. My sixth point examines the treatment for depression, psychological and medicinal methods. We will look at what treatments are effective to help patients live with depression. And finally, we will come to a conclusion of our findings. The Hospital Anxiety and Depression Scale is a self-assessment tool for patients used by GPs, hospitals, psychologists, and the healthcare system to diagnose anxiety and depression in patients. Today we'll be looking at HADS for diagnosing depression in cancer patients. HADS was first introduced as a screening tool by Zygmunt and Snaith in 1982 at the St. James University Hospital, Leeds, in the Department of Psychiatry. HADS is used to detect the severity of depression by means of a scoring scale system. The higher the overall score, the higher the degree of depression, and vice versa. HADS has proven to be a valid tool to identify depression in cancer patients. We will cover this on the next slide in some more detail. Stern validates HADS as an effective tool to diagnose depression and psychological symptoms. He also mentions the National Institute for Health and Care Excellence recommend HADS for diagnosing depression in cancer patients. The evidence from Zygmunt and Snaith suggests in their studies of the validity of HADS that only 1% of 100 patients had a misdiagnosis of depression and anxiety using HADS. Stern gives evidence to suggest that HADS is used widely throughout the Society of Occupational Medicine. HADS has been suggested to be very reliable in assessing depression in cancer patients by multiple sources. However, there is information that suggests HADS can be associated with misdiagnosis of depression. Due to many variables, age, race, sex, and stage of the disease, Trask mentions that the one study was conclusive for disease-free cancer patients, but not conclusive in unstable patients. Trask examined a study from Ramirez, which mentions a 40% false positive rate using HADS in women with breast cancer. However, HADS does have some limitations of its effectiveness and reliability due to the number of variables included with depression diagnosis in cancer patients. Narvaez and Trask both concur that there is a need for more research methods to diagnose depression specifically in cancer patients. This is because not all of the symptoms of depression can be clearly defined. This takes us to our next slide. Symptoms of depression in cancer patients vary from patient to patient. Typically, a patient needs to present 4 or more symptoms of depression for at least 2 weeks before clinicians assess for depression. Some symptoms of depression can be associated with other conditions, such as cancer pain or anhedonia. This can lead to diagnosis of depression being dismissed. Depression in cancer patients is significantly different to healthy individuals. Smith recognizes there is a noticeable difference between symptoms which can have a detrimental effect on life expectancy of cancer patients. We will explore this more on the next slide. Pittman and Narvaez have observed a high rate of mortality in cancer patients in comparison to cancer-free patients. Why does depression in cancer contribute to a premature death? All the research we have covered so far has not given hypothesis or clear argument of the link between depression in cancer and mortality. Pittman explores that certain types of cancer are associated with depression. Metastatic cancers are associated with depression more commonly due to the patient's belief that cancer was self-inflicted and could have been prevented by stopping smoking, drinking, or having a healthy diet. The severity of depression has been observed to be worse with different types of treatments for cancer. Nardwise noted, the more the intense and intrusive the treatment, the higher degree of depression in cancer patients. This correlates to the link to depression between the severity of cancer and the severity of the treatment. This makes us ask, why does depression impact the expectancy of life? There are a number of theories why depression affects the life expectancy of cancer patients. One theory that Pittman suggests seems quite logical. He mentions that depression not being recognised in cancer patients is associated with a higher rate of suicide. However, Cerulli has been studying depression at a molecular level. His studies have found that when depression occurs in the brain, serotonin is released. It has been seen that serotonin feeds certain cancer cells. In some cancers, if a patient gets major depression, it can lead to a growth in several types of carcinomas, which can lead to an increased risk of mortality in cancer patients with depression. In the next slide, we'll briefly look at years to life lost. Botter has carried out a very thorough study looking at the average number of years lost of life with depression in cancer patients. His study looked at varied age group from 45 to 90, male and female, covering a variety of cancers. His study also included years to life lost in non-cancer patients. If you take a look at the graph, figure 2, the black lines represent non-cancer patients and average lifespan with depression. The blue lines represent different age groups for male and female. This shows a dramatic reduction in years of life lost due to depression in cancer patients. Although Botter has carried out a very thorough study, his study was carried out on Italian males and females only, so the results cannot be conclusive for the global population. In our next slide, we will look at the impact depression has on patients' lives, families and their caregivers. Depression in cancer has many implications on a patient's life, including their family and caregivers. The effects can be seen to play parts in psychological problems, family, spiritual, understanding of doctors' language about the disease, financial strain due to most patients not being able to work, and physical symptoms, which all contribute to depression. A study by Ree has shown that depression affects family members and caregivers of cancer patients as much the same way as a patient feels it. There are many different types of treatment for depression in cancer patients. We will discuss these on our next slide. There is an urgent need to treat cancer patients as soon as possible to improve the quality of life. Early treatment of depression in the first year can lengthen the overall survival rate by 2.25 years. Psychological therapies have proven to be very effective. Specialist counsellors in cancer services can offer cognitive behavioural therapies to help cancer patients overcome depression. Antidepressants are widely used to treat depression in cancer patients. However, it has only been proven to help depression in certain cancers. Antidepressants are not always prescribed due to interactions with cancer treatments. Some antidepressants can have an additive effect on cancer drugs, such as chemotherapy. Some antidepressants used to treat breast cancer patients reduces the effect of chemotherapy, which heightens the risk of relapse. This point brings us to a conclusion of our findings. PAD seems to be the most widely used assessment method to diagnose depression in cancer patients, but there are other effective methods which are not used as often. HAD is valid and trusted, but this view is contradictory of all the data. Research has shown that HADs can lead to a misdiagnosis of depression due to some of the symptoms of depression can be associated with other illnesses. Therefore, HADs cannot be seen as fully reliable as an assessment method. The symptoms of depression can vary quite widely between different types of cancer. As stated before, some symptoms could be due to other illnesses, which can make diagnosing depression in cancer patients very difficult. The information we have covered gives evidence that depression shortens the life expectancy in cancer patients. This seems to be the general observation from a majority of the sources. This outlook could change. With the correct treatments, depression can be reduced in both patients, families and caregivers. Simply prescribing antidepressants to numb the effects of depression seems futile. Maybe more cognitive behavioural therapies could be used. This would enable cancer patients to understand their depression and not just live with it. Antidepressants do help in some cases, but they can also inhibit the effectiveness of chemotherapy. Perhaps antidepressants could be used with more caution and interactions should be studied more. There are lots of studies ongoing to treat cancer. Some studies prove to be very effective in finding solutions to beat cancer. However, more studies and research is needed for depression in cancer patients. The information in this presentation suggests that depression in cancer can be a major cause in mortality of cancer patients. Thank you for your participation. I hope you find the research and my arguments interesting